You're listening to Streetside, a Street Medicine Institute podcast.
Hello and welcome to Streetside. I'm your host, Michael Brennan. Conversations at the intersection of healthcare, homelessness, and humanity. We are very pleased to welcome Dr. Theresa Nguyen. She is one of the leading voices in academic street medicine in the country. She combines emergency medicine, medical education, community health, and street outreach to people experiencing homelessness. She is a professor of emergency medicine at Loyola University Medical Center and serves as director of the Center for Community and Global Health at Stitch School of Medicine. Theresa, welcome to Streetside.
Thanks so much. Happy to be here.
We usually like to start by having guests introduce themselves a bit. So our question would be, what was your path to emergency medicine and more specifically to street medicine?
Yeah, so I would say my pathway to emergency medicine was definitely more intentional. Obviously, when I was in training street medicine, I don't even know if it was a thing. So kind of happened to chance on that, but I'll back up a little bit. I'm actually originally from Pennsylvania. So I did actually all my schooling and education there, including undergraduate at Carnegie Mellon University and then medical school at Jefferson Medical College in Philadelphia. Throughout all those experiences, I'd always been very much passionate about working with underserved populations, largely because my own parents are immigrants, came to the U.S. during the Vietnam War. I've always been fortunate to receive a lot of, services as well as a lot of support from the local community. And so we grew up wanting to give back to that community and wanting to continue to, pay it forward in whatever capacity possible. So during my time in Philadelphia, I would volunteer at some of the community health clinics that were offered through our medical school, as well as working at the local immigrant clinic that we also had through Jefferson, helping with interpretation and also helping new families as they were arriving into the city. So that was the majority of my service that I did during medical school. And when I was trying to decide what to do as a specialty, I knew that I wanted to incorporate aspects of still being able to work with underserved populations, but having a skill set to be able to do a little bit of everything. And emergency medicine fit right in with that. At the time, too, I was also considering a career in global health. When you think about, again, the skill sets, being able to work in any environment from acute to non-acute, emergency medicine was the best pathway for that, at least at the time. So I went on to do my residency at Christiana Care in Delaware, which is a very large level 1 trauma center. It's located in Delaware, but it's actually the only level 1 trauma center between Philadelphia and Baltimore. So we saw it was a high volume, high acuity emergency departments. I got really well trained during those 3 years there and just being comfortable again with a little bit of everything and building up that skill set to be able to work in different conditions and different environments. As I progressed throughout my career, still trying to explore, did I want to do global health full time? I had actually considered doing a fellowship, but then just with family constraints and just the timing of finishing residency, I decided to work full time. But in those early years, still really trying to stay engaged with the community, and whether it was in a local or international capacity. So in the first few years, I was doing a lot of medical mission trips to places in Vietnam, as well as in Haiti post-earthquake, as well as Dominican Republic, just to name a few. And then as we kind of transitioned to different stages of my career, I was trying to figure out, again, that whole balance of family and having kids and not really being able to travel as much internationally anymore. And so just really focusing my efforts back more locally. So I ended up at Loyola in 2015, again, trying to think about how I wanted to continue to be able to use my skill sets as an emergency physician and continue to advocate for patients and contribute to the local community. So I became involved with our Center for Community and Global Health here, which is very much rooted in a mission of social justice and health equity, where we're working with community organizations, where we're engaging with advocacy efforts, and it's working with community partners in a very meaningful and sustainable way. And so I slowly transitioned from being a faculty member as part of our Center for Community and Global Health to assistant director and now director. And that's really honestly what paved the road for me even being involved in street medicine to begin with. And so a few years ago, we invited both Dr. Jim Withers and Dr. Jim O'Connell to give talks for our honor students about street medicine. And, immediately all the students were like, why don't we have a street medicine program here at Loyola? That kind of really just opened up a whole can of worms we had a group of really motivated and excited students who started reaching out to other local and regional street medicine programs just to get a sense of how do they do things there with student-run programs. And I guess the rest is history. So 6 years later, I have not looked back.
Tell me about that program then. When you say the rest is history, what has become of Loyola Street Medicine? Would you have students, attendings, any full-time staff, provider staff? What does it look like?
Yeah, so our official established date was January of 2020. So when you think about what was going on just in the months after that official launch date, we had all of these, plans and these visions. And literally, once COVID hit in March, we had to completely revisit all of that because a few of the community partners that we were working with were still trying to figure out what are they going to do under these, conditions, right? So one of our community partners that we work very closely with, Housing Forward, they had to figure out what they were going to do with all of their clients. And at the time, they were doing a rotating PADS shelter model. And clearly with churches being shut down and pretty much everything being shut down, that was no longer even an option. And so they had to very quickly relocate many of these clients to different hotel sites within the area and then try to figure out, okay, how can we make sure that they're not going to get lost to follow-up, that they're going to need the medical care that they need, as well as their social needs, and even just, are they still able to maintain their jobs? Are they aware of the social isolation precautions and what they should be doing? And so in the early stages of the program, we really were just working along Housing Forward during the pandemic, basically to kind of get through as best as we could. I mean, I think we were all in survival mode, right? I think everybody can empathize with that, right? As there were so many unknowns. And, once things got a little bit more stabilized, Housing Forward actually was able to initially lease an unused hotel and actually transfer everybody to one specific site, which made it a lot easier. And so once that actually got more stabilized, we were able to kind of go there. We were able to do weekly clinics at the hotel, education sessions. Once the COVID vaccine started rolling out, we were able to do vaccinations there. And again, just providing a little bit more regular care as opposed to kind of this piecemealing. And so that was really the first year of Loyola Street Medicine. And from there, we worked with another community partner, the Night Ministry, and based on the January point in time count, found that nearly half of the unsheltered homeless were using the CTA, the Chicago train, basically, as their primary means of shelter. And so that provided another opportunity for us to expand our outreach. And so since fall of 2021, we have been providing medical outreach to individuals experiencing homelessness at a local train station here in Forest Park. And we're there every Thursday night from either 7 p.m. to 11 p.m. or 8 p.m. to midnight. In addition to the medical services, the Night Ministry is also there. They provide a social worker. There's a harm reduction specialist. There's usually hot meals. And in the last few years, we've been able to provide specialty services like dental, ophthalmology, some legal aid services as well whenever we're able to get volunteers. And in the last year, we've been able to provide a wound care nurse as well as a street psychiatrist. So lots of room for expansion still, but I'm pretty proud of how far we've come.
I'm curious, would that street psychiatrist be Sam Jackson?
That is correct.
Okay, because he was our most recent interview.
Okay,
We just published an interview with Sam on May 23rd.
Yeah, that'd be a great segue.
Yeah, that's great. It sounds like you provide a robust menu of services. So let's transition a little bit. That's your street program. The impetus for inviting you on this program was really to talk about the consult service, the inpatient consult service, because we have not focused on that in this podcast yet. And I'd really like you to take it from the top. What is an inpatient consult service for those that are unsheltered? What does that mean?
Yeah, so this is something that we established in March of 2023. And actually, I had come back from one of the International Street Medicine Symposiums where another program had presented their inpatient consult service. I was really inspired by the work that they were doing and wanted to see if we could model something really similar. And so I think a lot of the inpatient consult services function a little bit differently. I think it comes down to staffing and availability. But at the root of it, it's really trying to provide that bridge for patients experiencing either homelessness or housing insecurity from the time they're in the hospital to discharge, and making sure that there is a safe discharge plan, and making sure that while they're in the hospital, their needs are being addressed and that they're being connected with resources as best as possible.
Is it a medicine and psychiatry program when they're inpatient?
So when they are admitted to the hospital, they can be on any service. So I think it's different at each hospital, but for Loyola specifically, because we are a big level 1 trauma center, I can see patients that are admitted to the burn unit, on the trauma service. They could be admitted to like the general medicine service or any number of admitting services here at the hospital. So it's not specific to any one specialty.
Okay, and who's managing the withdrawal symptoms of substance use disorder?
So in the hospital, it's the primary care team that's taking care of the patient.
So are they all well versed in management of substance use withdrawal?
I would say that they are aware of how to manage patients in the hospital, but once the transition needs to happen to the outpatient setting, then that's usually when we will have to consult either psychiatry or any of our addiction medicine specialists.
Okay, and when you say we, to whom are we referring? What's your team?
Yeah, so our team is the inpatient street medicine consult team. Typically consists of either myself, 1 or 2 medical students, and or perhaps a resident that might be rotating through on a street medicine elective.
So it's mostly you, is what I'm hearing in that. Like you're mentoring some students and a resident, but it's you are the inpatient consult service.
I run it all year round, yes, but I do
Yes.
have help with the students and the residents that are rotating throughout the year.
Okay. Okay. And what do you find most challenging in doing that role?
I think the lack of available resources for patients, especially with the current political climate, as well as the lack of funding for a lot of programs. We've noticed that I'll give you patient cases as examples, just because I feel like those are the cases that
Yes.
hit home
Please do.
the most, right? So, for example, I was consulting on a patient who had been assaulted by his nephew, who he had been staying with. And so he was assaulted by his nephew in the house that he was staying at. And so unfortunately now the nephew is under arrest. The patient is in the hospital dealing with traumatic injuries related to the assault. And the house, which he can no longer return to, is a crime scene. And also his name isn't even on, the deed or the lease or anything. So he really actually has no actual rights to return to that house anyways. During the course of his hospitalization, it was discovered that they had lost his ID, they had lost his social security card. And even though he had insurance, there was no way to verify his insurance or his social security because of these lack of ID cards. And because this was also happening during the government shutdown, we couldn't even call the social security office to verify. So now we have a patient that's effectively stuck in limbo, who really should be eligible for services. And by services, I mean he should qualify for inpatient rehab, but there is no way to verify that so he could actually get placed into a facility. So ultimately he was now deemed homeless. Now the primary care team basically is consulting us to say, can you find him a place to go? Right. And so at this point, a shelter is obviously not an acceptable or an appropriate place for somebody to go who's recovering from traumatic injury, who has a walker, who's struggling to get up and down the stairs, but really needs acute inpatient rehab. And so I got very lucky in that with the timing of the consult and also the location with where he preferred to go, that there was actually an open medical respite facility that was willing to take him. And in addition to that, this medical respite facility was close enough to the police station that they were going to work and maybe see if they could have a police escort back into the house to at least grab his things and perhaps maybe find his ID or social security card. And so that was, it was a complicated situation with an ideal discharge plan, but that's not always the case. And I think that a lot of times, and I say this a lot to the students too and the residents that come through is we'll celebrate those wins, because those wins often really I'd say they're probably the exception and not the norm.
Right. We need to celebrate them because it is so difficult in this work to achieve what the outside world would call success. But I'm sure just your being in relationship with patients is success unto itself sometimes. I'm curious then, with the inpatient consult service and the Loyola Street Medicine teams, it sounds like you're trying to provide continuity of care between the inpatient and outpatient worlds. And
Yes.
you are you and your person, Theresa Nguyen, is the bridge. How does that actually play out? Do you end up seeing the same clients inpatient and outpatient yourself?
Yes. And so those are sometimes, again, we'll celebrate those wins and those ideal scenarios. So for example, I might see a patient on a Thursday night at the CTA clinic. And let's say we'll call him Joe. And Joe has a wound infection that I'm really concerned about. I will tell Joe, please, I'm really worried about you. Can you go to the hospital? Because I think you need to get some images of your wounds, perhaps maybe some IV antibiotics, and probably be admitted to the hospital. And there's often a lot of reluctance for these patients to come to the hospital, right? For many reasons, whether it's they've had bad experiences or they have other competing priorities. At least having a baseline relationship with this individual can help support their willingness to go to the hospital. So I can say, Joe, if you go to the hospital, I'm going to call my friend. They'll keep an eye out for you so I can give a warm handoff to my ED colleagues. And then typically, if I have students with me that are also on the elective, I will introduce the patient to the students. And I'll say, here's these students. They're going to come see you tomorrow. Tell us what you need. And a lot of times on the consult service too, we're bringing them supplies. We're bringing them books to read. We're bringing them things to also help pass the time in the hospital and help them make them feel as comfortable as possible. And when you can do that warm handoff, it's an ideal situation, right? So then Joe gets admitted to the hospital. Then we see him the next day. We're bringing him things he needs. We're addressing any concerns that he may have, and we can follow him through that hospitalization. And depending on what his needs are at discharge, we can also try to do our best to make sure that he's connected with all the resources. Maybe he already has a case manager at the night ministry, and maybe we can just contact the night ministry and say, hey, Joe's ready for discharge. When can you meet him? Or in many other cases too, we'll have case managers that will come and pick the patients up. And so those are things that I think can really help facilitate making this a positive experience for everybody, not just the patient, but I think for the hospital teams. And I think that's a really great example of how street medicine inpatient consult services can really be that bridge.
And I love that story because it also brings in the emergency room, inpatient, and there's emergency. And in my experience, and I'm in Rochester, New York, and the local emergency rooms do not treat my patients very well. If I refer my patients to the ED, they're likely to be stigmatized for their substance use and looked at through a jaundiced eye because of their unsheltered status, and they are not treated well, and they hate it, and they wait 6 hours and they start to go through withdrawal. There's just not a kind of a culture of caring that they encounter, and it's not rapport, it's not relationship. They really feel stigmatized, and they often leave then on their own volition. They'll give up, and I wonder then, you being an emergency room physician, do you feel like you've been able to bring about some culture change in the emergency medicine approach to the street medicine clients?
Oh, absolutely. I think inherent in this work also is the education that goes with it, right? So that education is not just for medical students and residents, but it goes to providers and nursing staff as well, right? And so since I've been a part of the street medicine program in the last several years, I've really made it an effort to provide education to all of our staff in terms of how can we holistically care for these patients and treat them in a humane way, right? Like I think we've all heard comments about, oh, so-and-so is back again, or, so-and-so is asking to eat again. And, there's these comments about, oh, well, we're definitely not going to give him a sandwich today, or, you wouldn't withhold food from anybody. So, I think just remembering that there's still humanity and dignity in all of the patients that we serve.
How successful have you been in those efforts? Like where are you at on your job satisfaction with bringing about cultural change?
I'm a glass half full as opposed to a glass half empty kind of person. So I'd like to think that there has been a decent amount of progress in terms of not just being able to address these patients in a more holistic manner, but also knowing what resources to provide and what history to take and how to really sit down and take the time with the patient rather than just, making a snap judgment.
So I would like to ask Theresa, for other street medicine programs around the country that want to do something similar in terms of an inpatient consult service, what advice or recommendations would you give them for making this happen?
Yeah, I think hospital buy-in is a big part of it, right? I think it helped that we were pretty well established in terms of showing the impact of the patients that we've been seeing at the CTA train station. We had actually done a lot of initial research to look at ED utilizations for patients experiencing homelessness and housing insecurity through the ED, as well as potentially patients that were bouncing back more frequently. And so just being able to get hospital support for this is helpful, and then being able to monitor the impact that you're having. I think first and foremost, you're also going to have you're going to also need at least one and or two people that can help cover the consult service, right? And staff the new consults that you're seeing. And so for me, because I already had a lot of relationships with these patients at the train station, and being able to build those relationships over time, and we also keep a running list of all of the patients that we see in our EMR list. So I can also, get a sense of who's bouncing back. I can also sometimes get ahead of the consult. So if I see that Joe has bounced back and he's on my list, I'm going to just, message the primary care team and say, hey, I know Joe very well. I'm happy to see him. This is where we left off last time. And really kind of connect those dots as best as we can. But I think in terms of overall advice, I think staffing is key. Being able to keep records and be able to connect with patients both in and out of the hospital is pretty essential. And I think also, I mentioned this briefly, but this might be a good segue, is just how important having a medical respite partnership is. And so for those of the listeners who are not familiar with medical respite, it's effectively a place for patients to recover who are perhaps not sick enough to be in the hospital, but not something that we want to discharge to the streets either. So, patients that still require antibiotics, or patients that have had surgery and still have wounds to care for, are a big population that tend to fit that medical respite need the best.
Fantastic. Love your program. Love what you're doing. We're wrapping up. So this is the question I ask all my guests is, what question do you wish I had asked? Is there something out there that we haven't talked about that you wish we had?
In the podcast today?
Yeah. Just in this interview. Is there something else you want to share?
Oh, something I did want to mention is, have you used the house beds, or have you discussed house beds at all in your previous podcast?
Please do so. I know it was part of the symposium, but please share it.
Yeah. So one additional thing that I did want to mention that I feel that anybody working in the clinical setting should be aware of, and especially if you're going to be taking care of any patient struggling with housing insecurity or homelessness, is an understanding of the house beds clinical tool. So this is something that came out of Brett Feldman and the USC team, who are doing fantastic work. And they also have a fairly well-established inpatient consult service. But the house beds tool is a clinical tool for taking a history in an unsheltered homeless patient. And so every letter of that house beds give you a different component of the history. So H is housing, O is outreach, U is utilization, salary, daily routine, substance use. And so all those components of the house beds tool can give you that big picture of what's going on with the patient. And that's, I think, so crucial to be able to make discharge recommendations, being able to understand competing priorities in terms of understanding what is the patient's day-to-day life, and how can we help make a patient-centered discharge plan that's going to work based on that house beds information. And so all of our consult notes actually include house beds information as part of our standard consult note.
Theresa, run through it one more time. It's an acronym. It's HOUSE, HOUSE.
Let me make sure I got all the letters straight here. So, and I can, if you want, you can share, I'll send you the link that you can share with your listeners, but this is something that everybody should be familiar with, and everybody, again, working in the clinical setting with patients experiencing housing insecurity or homelessness should be aware of. But the H is homelessness history. So how long have they been homeless for? What were triggers for their homelessness? Where have they been staying? Outreach engagement is really centered around, are they already working with a specific organization? Like for us, have they established care with any case managers or the night ministry or any organizations? What's worked? What hasn't worked? A lot of times we'll get answers for this and they'll say, oh, I tried to reach out to this organization, but they never got back to me. Or, I'm already connected with a case manager. And so that's helpful too, in terms of knowing who to reach out to, or if a patient did not have a great experience with this one organization, we're not going to try to call them again. U is utilization. And so that is more of how Are they tapped in with a primary care physician? Do they have insurance? How often are they showing up to the hospital, the ED? Are they frequent utilizers? And then in addition to that, what sort of social services are they already linked into? As part of this too, we also ask about any sort of incarceration history or any legal issues too that we might need to address or consider. The S is salary. So what is their current source of income, if any? Gives us a sense, can they afford to live somewhere on their own? Maybe for patients that are 65 and up, do they have the income to perhaps maybe go to an assisted living facility or one of the senior living facilities? So that again, it gives us a sense of what are their competing priorities, right? Because some people might have a source of income, but they have a lot of debt and they have other things that they need to pay for, like a car payments and things like that. And then the rest of it is eat. So E is eat. So what are their sources of food and how do they access it? Are they panhandling? Are they going to fast foods? Are they going to convenience stores? So again, this is also relevant in the setting of the hospital for somebody who might be diabetic or congestive heart failure or high blood pressure. And so if they don't have access to consistent and nutritious food, how do we expect them to stay out of the hospital, right? The D is drink. So what are their sources of clean water and how do they access it? So are they showering? Are they using gas stations? I've recently heard that there's a few patients that actually maintain their gym membership because they can actually shower there and they can change their clothes there. And then the B is bathroom. So what access do they have to the toilet? E is encampment. So what's their current sleeping environment? Where were they most recently staying prior to the hospitalization? Ideally, where would they like to go afterwards? And then the daily routine, right? What's their day-to-day life like? Are they working? Do they have kids? Are there other family members in the picture that we need to be considering? And that gives us a sense of how can we address some of their competing priorities. And then finally, the last S is substance use. So that's, I think, pretty self-explanatory. But again, you can think about how this gives us a really big picture of what's going on with a patient. If you don't ask these questions, you can miss vital pieces of information that could potentially make or break their discharge plan and their willingness to follow up or, be compliant with their treatment.
Fantastic. If we want to provide comprehensive holistic care, we have to get comprehensive and holistic information. That's a very useful tool. I appreciate you sharing it in detail. And we're coming to the end of our time. So I'm going to give you another opportunity, if you wanted to share another patient win, another patient vignette to demonstrate the beauty of the wraparound.
Yes. So we actually were just talking about this one patient the other day because my medical co-director is internal medicine and pediatrics. So he's actually a primary care physician. And so our combination actually works out pretty well, right? Because, I can see patients more acutely in the emergency department. And then I have an option to refer patients to him in the primary care world. And so we actually have a patient that we've been seeing pretty regularly at the CTH train station clinic for years. He's young, he's in his 30s, and really had a very difficult upbringing. Both of his parents struggled with substance use disorder, mental health, and addiction. And he actually found his mom after she overdosed. There was already a lot of odds, stacked against him. And so after his mom passed away, he was living with his dad for some time. His dad actually struggled with substance use and alcohol use disorder as well, and ended up in rehab for a short time. So this patient ended up living with his aunt. During this time period, he got involved in a really bad car accident, and the car accident resulted in him losing part of his left leg and part of his left arm. And then he, as a result of that accident, had a lot of complications, suffered from worsening mental health issues, and then worsening substance use disorder, to cope. And so the first time I met him at the train station, I'm seeing this, young patient who's, hobbling around in like a broken wheelchair with wounds and, so many things going on. And so we really built a relationship with him over the years. He had been bouncing back and forth between a lot of different hospitals in the Chicagoland area. And he had a lot of complications from his wounds, and he really actually needed a higher up amputation of his left leg. So he actually, at this point, he had a below the knee amputation, and he really needed an above the knee amputation just based from like the wounds and the infections he was getting. And just because of his housing situation, his substance use, his mental health, nobody would agree to operate on him because, for many, many reasons. And we ultimately got him transferred to Loyola for care. We were finally able to actually accept his insurance. And so he started coming to Loyola for care. Our entire team knew him. So anytime he was in the hospital, we would go visit him. And he finally got that surgery that he needed. He had some complications after the surgery, but again, it helped that we were there pretty much every step of the way. I actually got to meet his dad. I got to meet his aunt at one point. And so that was a really great experience. And then at the end of the day, because of his disability and, his post-operative needs, he was eventually able to get approved for housing through the case manager that he was working with. And so he's currently housed, and now he actually still comes to Loyola for follow-up. My medical co-director, Dr. Boblik, who's med peds, now sees him as his primary care physician, and he's doing incredibly well. He's happy, he's healthy. He's working on getting clean, but he's a different person now. So
what a beautiful story with such a hard road for that patient.
right.
What I'm taking away from it is it's the relationships, it's the support, the community that forms around our clients that can be healing.
For sure.
Medicine is just a small part of it. It's the kind of the love and the care that people put into folks that then bears fruit. Thank you so much. We ask all of our guests a final question, and that is, if you could do one thing to make the world a better place, what would it be?
Healthcare and housing for all.
Great. All right. Winner. That's a great answer. Dr. Theresa Nguyen, thank you so much for taking time out of your busy day to talk to us on Streetside. We wish you all the best at Loyola and with your inpatient consult service. Thank you.
Thanks so much.
The Street Medicine Institute is a secular, nonpartisan organization. Any spiritual or political views shared by guests on Streetside are their own. They're offered in the spirit of conversation and should not be taken as reflecting the views or positions of the Street Medicine Institute. This podcast should not be used for personal medical guidance. Please consult your healthcare provider.